Hi, everyone. Welcome. Thank you for logging in. We'll get started in just a couple minutes. Hi, everyone. Good evening. Good evening. Thank you for logging on. We'll get started in a couple minutes. Hi. If you have any initial questions, feel free to start using the comments section now, and we'll make sure that we get those questions answered throughout the seminar. Hi, everyone. Thank you for logging on. Good evening. All right, let's go ahead and get started. Hello,
Okay.
everyone, and thanks, Dr. Wahl.
Yeah.
Hello,
Go ahead.
everyone.
Sorry.
No problem. Hi, everyone, and welcome to the virtual patient seminar. My name is Lauren Landman. I'm a representative of Ortholine, a medical technology company. Today, we've partnered with orthopedic surgeon Dr. Jeffrey Wahl from Guthrie County Hospital in Guthrie County, Iowa. We're holding this educational seminar to discuss the advancements in total knee replacement. Since the seminar is hosted on Facebook Live, all attendees are muted and your cameras are also turned off. If you have any questions during the presentation, I invite you to start to type those into the comment section that will be located below your screen or to the right. So whenever you have a question throughout the seminar, please feel free to type it in and we'll make sure we get your questions answered. I'll also be notified when you type in this question or these questions, so we'll have plenty of time at the end of the presentation to make sure we get those questions answered. So without further delay, Dr. Wahl, the controls are all yours and we can begin as soon as you're ready.
Okay. Thank you, Lauren. And welcome, everyone. Thank you for joining us this evening. Whether you're watching live or at a future date, we sincerely appreciate your interest and viewership. Tonight, we're going to be talking about osteoarthritis, which is a topic that's near and dear to my practice. And if you're watching, I'm guessing it's probably near and dear to you as well. The focus of this talk is going to be about how I use technology in knee replacement surgery, but the talk itself is not exclusively about technology, and it's not even exclusively about knee replacement surgery. We are going to be covering, the basics of osteoarthritis and how we treat it, whether it's surgically or non-surgically. So if you're tuning in and you just want some general information on osteoarthritis or what it is, how we treat it, I think you'll still find the talk helpful and beneficial. Like Lauren said, if you have any questions throughout the talk, go ahead and type those in. She'll be monitoring for questions and comments. She'll hopefully keep me on task and make sure that I don't say any naughty words either. So with that, we'll get started here. So my name is Jeff Wahl. I am a board certified orthopedic surgeon, and I have been in practice for over 14 years. I'm originally from Jefferson, Iowa, and that's where I graduated high school. From there, I went to Simpson College in Indianola, Iowa, and then went to medical school at Des Moines University. From there, I did my orthopedic residency in Cleveland, Ohio for 5 years. My wife, Becky, is also from this area. In fact, she's from Guthrie Center. And we knew through residency that we would eventually want to come back and practice in Iowa, but neither one of us necessarily thought that we'd have an opportunity to practice in our hometowns. But fortunately, things worked out the way they did. So I am hospital employed. equally at both Guthrie County Hospital and Guthrie Center, um, and Greene County Medical Center in Jefferson, Iowa. Before we get too far into the meat of things, I just want to take a moment to acknowledge my team at Guthrie County Hospital, especially my surgical team. We have an awesome group of nurses, and Chelsea, our surgery technician. Um, and they've been with me every step of the way over these last 14 years. Simply put, I couldn't do what I do without them. And whether you're, as much as I would like them to exclusively work for me, they don't. They work for the hospital. So whether you're coming to get a knee replacement, or you're coming to get a colonoscopy, or you're bringing your kid for ear tubes, you're going to see these girls and they're going to take good care of you. So from left to right there across the picture, we have Larissa, Chelsea, Steph, Cassie, and Bree. I'm sure for some of you watching, those faces and names will be very familiar to you. Well, like I said earlier, today we're going to be talking about osteoarthritis, and specifically, we're really going to focus on osteoarthritis of the knee. Some of what we talk about will apply to the hip, the shoulder, but for the most part, we're going to give most of our attention to the knee. We're going to talk about symptoms, treatment options, and then how I use technology and knee replacement surgery. So what is osteoarthritis? Believe it or not, it's actually a bit of a misnomer. If you break the word down, arthro means joint and itis means inflammation. So simply put, arthritis is inflammation of a joint. And we could be talking about any joint, whether it's the hip, the knee, the shoulder, even the small joints in the fingers. And why it's a bit of a misnomer is because osteoarthritis is not necessarily always inflamed. Osteoarthritis is a progressive degeneration of the joint. And at times it can be inflamed, but for the most part, it's just sort of wear and tear of the articular cartilage of the joint. So it is a bit of a misnomer. It's also commonly referred to as degenerative joint disease. And sometimes we'll just shorten osteoarthritis and call it arthritis. But the reality is there's over 100 different kinds of arthritis. The majority of arthritic cases fall into the osteoarthritis category. So that is the most common form of arthritis. It's often confused with rheumatoid arthritis, which is truly an inflammatory form of arthritis that affects joints. But osteoarthritis is the progressive degeneration and degradation of the cartilage of the joint. And we do not know what causes it. We do know there are some risk factors, only one of which is modifiable. Genetics, which is not modifiable, is absolutely a risk factor. So if mom or dad or grandparents have arthritic joints, there's a chance that you could get them as well. Trauma is also a major risk factor. And I'm not talking about, well, I bumped my knee into the coffee table last night and I've been doing that a lot lately. We're talking major trauma to the joint, whether it's a fracture that extends into the joint surface and disrupts the joint surface, or a major ligamentous injury to the knee, like an ACL tear. And trauma in and of itself is not modifiable. Sometimes it's preventable, but it's not modifiable. The other risk factor and a major risk factor is weight. Obesity, there's a clear link between obesity and arthritis. And in my practice, I'm seeing more and more relatively young patients who come in with fairly advanced arthritis. And we're talking patients in their late 30s, 40s. They're far too young for a knee replacement, and yet they have quite advanced arthritis on their x-rays, and those present a bit of a dilemma and challenge to surgeons. And once again, that is the only modifiable risk factor. And of course, that is obviously the hardest risk factor to modify to losing weight. I think it's important to mention that not all joint pain is arthritis. I think too often we've kind of trivialize joint pain and say, well, it's just arthritis. Lots of things can cause a joint to hurt. Certainly, if you have any of these signs here where you find yourself no longer participating in activities that used to bring you enjoyment, maybe a walk around the park or the track, maybe you're sneaking closer into those parking spots, closer to the entry door, so you don't have to walk as far because your knee hurts. You find yourself riding in the elevator instead of taking the stairs. It's not because you get short of breath. It's because your knee hurts. Certainly all of those could be signs of arthritis. It also could be a sign of something else. So the bottom line is if you do experience consistent joint pain, it's important to get it checked out. It could be arthritis. And in my practice, if I have an individual that comes in with joint pain, in particular knee pain, and they're over 50 years old, 9 times out of 10, it's because of arthritis. If they come in and it's their hip hurting, I would say 7 to 8 times out of 10, it's because of arthritis. If they come in and they tell me their shoulder hurts, I would say half or less than half of the time it's arthritis. Usually the majority of shoulder pain that I see in practice is because of rotator cuff pathology, not necessarily arthritis. So the bottom line is if you have an achy joint that's consistently been bothering you for some time, it's important to get it checked out. All right, so once again, osteoarthritis is the progressive breakdown or degeneration of the cartilage cushion of the joint. It's obviously extremely common. The most common form of arthritis, as I mentioned earlier. The exact cause we don't completely know yet. And sometimes we will divide arthritis or categorize arthritis into either mild, moderate, severe. And we can do that by looking at x-rays. So if a patient comes in and gets x-rays, what we're looking for is spacing between the thigh bone and the shin bone. X-rays can't show us cartilage though. So how can we know if there's arthritis? If arthritis is the degradation of the cartilage, but we can't see the cartilage on the joint or on the x-ray, then how do you know there's arthritis? Well, once again, we're looking for spacing. Spacing tells us if there's sufficient cartilage in the joint. And if the patient comes in and we see that the thigh bone and the shin bone are directly touching each other, there's no space on the x-ray, then that means there's no cartilage in the joint. That is, what we call bone-on-bone arthritis. If they come in and there's maybe a little bit of joint space loss, we would call that or categorize that mild arthritis. If they come in and moderate, of course, would be somewhere in between advanced or bone-on-bone and mild. But sometimes x-rays can be misleading. Sometimes there's more cartilage loss than what the x-rays would lead you to believe. The best test would be to go in there and take a look. And sometimes we do go in and take a look. Usually we're going in and taking a look for other reasons. Maybe the patient had a torn meniscus and we happen to go in there with a camera to fix that. And while we're in there, we can examine the entire knee joint and we can see the quality of the articular cartilage. And these photos that I've provided here are intraoperative arthroscopic images inside of a knee joint. I'll start with because our pointer isn't working, I'm going to start with the upper left-hand picture. And that is a picture of a nice, healthy knee joint. What you're looking at 12 o'clock is the femur, not the bone, but the cartilage that covers the bone. That cartilage is about a centimeter thick. And below the femur at 6 o'clock is the tibia or the shin bone. And once again, you're not looking at bone, but you're looking at cartilage that covers the shin bone. And that is a nice, healthy looking knee joint. That cartilage is nice and smooth. And you'll notice all the other pictures, that cartilage does not look nice and smooth. If we work our way from the upper left-hand corner over to the right in that center picture, we can see this is the early stages, early beginnings of degeneration of the cartilage of the joint. We're seeing some fissuring in the cartilage, some flakiness in the cartilage. We probably categorize this as mild. Unfortunately, this is not reversible, and there's nothing I can do surgically to make that center image look more like the left-hand image. To the upper right-hand corner, we're seeing more progressive degeneration of the cartilage, flakiness of the cartilage. We would categorize that as probably moderate. In the lower left-hand side of the screen, I disregard that picture. It didn't transfer very well, but that's okay because the lower right-hand picture kind of tells you all you need to know. In that lower right-hand image, there's actually a probe that is touching bone. And so remember, in the first image, I said we shouldn't be seeing bone. We should be seeing only cartilage. So if we're seeing bone, that means that we have lost all of the thickness of the cartilage. And what you're looking at is bare exposed bone. In fact, you can kind of see the demarcation between some cartilage and virtually no cartilage. And that is advanced osteoarthritis. And once you get to that stage, that advanced stage, the bone-on-bone stage, there's really nothing short of a knee replacement that is predictably going to help greatly. And that doesn't mean we can't try some things, but it does mean we need to kind of, set our expectations. I need to counsel the patient that, hey, you're kind of on the path towards needing a knee replacement because there's nothing I can do to make this look or feel any better. We're doing good, Lauren. Comments, questions?
Doing great.
Okay, thanks.
Keep going. Thank you.
All right, moving on to symptoms. And the symptoms are what you would think they would be. Pain. And I just want to mention or make a comment about pain. Arthritis has often been described as a dull, achy pain. But I want to emphasize that, everybody's pain tolerance is, of course, different. Everybody's perception of pain is different, too. And arthritis doesn't have to feel like only one kind of pain. I think sometimes, people will dismiss how their knee feels and say to me, well, it's a sharp pain, not a dull pain. I figured if it was a dull pain, it must be arthritis. And if it's a sharp pain, it must be something else. And that's not necessarily true. Arthritis pain can feel dull. It can feel sharp at times. It can feel like there's catching, there's grinding, occasionally burning. So I wouldn't get too hung up on the kind of pain it is. The fact that there is pain is a symptom of arthritis. And of course, with arthritis comes stiffness of the joint, occasional swelling of the joint. Sometimes fluid can build up inside the knee, and that occasionally has to be drained. Crepitus is that grinding or grating sensation you might feel when you move your knee. And then I'll introduce these concepts now. We're going to kind of talk about them in more detail later in the talk, but this concept of varus and valgus. So you've probably seen people in the community, perhaps you yourself have seen it in the mirror. You might be a little bow-legged, you might be a little knock-kneed. Bow-leggedness we call varus, knock-kneed we call valgus. Um, and and what that means typically is that the cartilage on one side of the knee, either the inside of the knee or the outside of the knee, has worn down so much that now we have virtually no joint space on the inside of the knee, and that causes the bow-leggedness. We call it varus. If the arthritis was more advanced on the outside part of the knee, then that would cause a knock knee deformity. We would call that valgus. When I see a patient in the office who does have an obvious bowed knee or knock knee, I ask them, hey, have you had this your whole life? And if so, do you think it's gotten worse as you've gotten older? Some people are naturally born a little bow-legged or a little knock-kneed, but in cases, especially of advanced arthritis, sometimes that bow-leggedness or knock-knee deformity will worsen. Okay,
We do
so
have a question in the chat, Dr. Wahl. Sorry to
yeah,
interrupt. This patient experiences stiffness, particularly while walking around. Anything that you can talk about with feeling stiffness in the joint, specifically when using stairs? Any advice you can give this patient, or, if it's a symptom of osteoarthritis?
yeah, it certainly could be. Although especially in early forms of arthritis, early degeneration of the joint, the patient will often experience what we call startup pain and stiffness, where after they've been sitting for a while, they go and they stand up and the knee is stiff, and then once they kind of take a few steps, then things loosen up and they feel better. So if it's sort of stiffness throughout the walking, it still could be arthritis. It could mean there's something else going on. Pain with stairs, stiffness with stairs, that absolutely could be arthritis. In particular, underneath the kneecap, which is not an uncommon place to get arthritis of the knee joint. Those patients, classically have difficulty with stair ambulation, squats, and lunges. So it may be worthwhile. The easiest thing to do, of course, would be to either see me, see your family doctor, and get an X-ray of the knee. That would be the best place to start.
Thank you. And the
Uh,
patient did clarify, feeling the stiffness more upon waking up. So it could be, like you're saying, in those stages of sitting for a long time, just getting the
right,
joint moving again. So thank you
right.
for clarifying. And I did put the form and the phone number to contact Dr. Wall's office in there.
Okay. All right. Thank you. Um, well, speaking of pain, it's important, I think, for the surgeon to know how much does this pain affect you. And of course we have these pain scales, and we can attach numbers to them. And then, like I said earlier, everybody's pain tolerance is a little different. So I don't know that we put as much stock into the number itself, but what we want to know or what I want to know from the patient is, how much does this really bother you? I've had a number of patients over the years that come in to see me with X-rays that show significant advanced arthritis of their knee. It's bone on bone. But if you talk to them, they'll say, well, it only bothers me a little bit, or I get by fine with just an occasional Tylenol. And so there's no reason to operate on an individual like that, even though their X-rays look advanced. Certainly, we don't treat X-rays; we treat people. And the opposite could be true as well, where you have a patient whose X-rays really don't look that impressive, um, and yet they would have you believe they're in a world of pain. And sometimes we got to work through that and figure out why their knee hurts so much. So to me, what matters more is not, like I said earlier, whether it's a dull pain or a sharp pain. And the number that we assign to the pain isn't as important as, has this pain really kept you from doing what you want to do, from enjoying your life? Do you feel like your quality of life has suffered because of your knee pain? That matters to me, I think, far more than anything else. Okay, so um, treatment options. What do we do? Well, you'll notice, and it's no coincidence, the first thing here at the top of the slide is weight loss. Like I said earlier in the talk, it is a risk factor, and it's kind of the only modifiable risk factor. It's also the hardest thing for people to do. And sometimes we need to get the family doc involved, the internist, the dietitian, or a weight loss center. We know that um, patients with obesity, it's not that they can't benefit from knee replacement surgery. I mean, their patient satisfaction scores are just as good as non-obese patients. It's just that their complication rate is higher. So they're a riskier surgery. So this is an elective surgery, and we're placing artificial components into the knee when we replace it. Those components could get infected, and that is a major problem. So we want the patient coming into surgery and with relatively healthy weight, so that we minimize some of these risks. Um, Rehabilitation or therapeutic exercises. Sometimes patients will kind of squint their eyes when I suggest doing some physical therapy or poo-poo it. What I tell them is, I think therapy, well, let's be honest, therapy is not going to reverse these arthritic changes, but therapy does help strengthen the muscles around the knee joint, and that helps take some of the load off the knee joint, and transfers it into the muscles, thereby helping alleviate some pain. It also helps improve the range of motion of the joint, but also a number of these patients, like I said earlier, are kind of on a pathway towards needing a knee replacement. And the patients that do the best after surgery are the ones that come into surgery with a knee that's well conditioned. It's in good shape. It moves well and it's relatively strong. The patients that I think struggle the most after a knee replacement are the ones that come in with a knee that was super stiff and super weak. And they think a knee replacement is going to take away all their pain. And unfortunately, that doesn't happen, or at least it doesn't happen right away. It takes quite a bit of time to get that muscle strength back. Um, Knee bracing. No scientific study has ever shown that a knee brace alters the natural progression of arthritis. Having said that, if a patient wants to wear a brace, they feel like it's helpful, it helps minimize their pain. I'm all for it. As long as it doesn't hurt you, I think it's a reasonable option. There's probably some benefit from the compression around the knee. Um, what we call an unloader brace might be a better option. An unloader brace is for the patient who has arthritis that's kind of confined to just one side of the knee or the other. And this is an unloader brace is more of a custom brace that we order that helps kind of transfer the weight from the arthritic side of the knee to the non-arthritic side of the knee. It kind of opens up that space more. They can be expensive, and insurance unfortunately doesn't cover the entire cost of those unloader braces. Um, and honestly, most people don't like wearing a clunky, bulky brace if they don't have to. And especially I think in the warmer months of the year where they're sweating a lot, they just don't want to wear the brace. So I will occasionally prescribe an unloader brace, but it's not often. One quick word about walking aids like a cane. It may seem counterintuitive, but if you're going to use a cane, actually put it in the opposite hand of the side that hurts. So if your right knee hurts, put the cane in the left hand, and that helps take the load off the painful knee. Without a doubt, the first line of treatment is over-the-counter medication, and we're talking Tylenol, we're talking anti-inflammatories like Advil, Aleve, Motrin, ibuprofen. Um, and those are, I'll say, relatively safe, especially Tylenol. But a lot of patients come to see me and will just kind of freely admit that they take more than they should, and they take up to the maximum dose on a daily basis. And if the pain is getting to that point, then it's probably time we start talking about doing something different. If you're just taking an occasional Tylenol, then once again, I don't see that there's any need to do anything more because you're functioning just fine. It could be that for those patients that have advanced arthritis but only need an occasional Tylenol, they're relatively low demand, they're not very active. And if they were more active, it would probably hurt more and increase their need for the Tylenol. So the next step, after the over-the-counter treatments, and really the first kind of line of treatment in a clinic is injections. And those come in two forms. Cortisone or a steroid injection is the old tried and true. And then we also have these lubricating gel injections. The main ingredient in those is hyaluronic acid. A few words about each of these. Cortisone injections are cheap. Usually we get a good response within a couple weeks. Unfortunately, they don't last very long. The effect kind of peters out over 3 to 4 months. And although you may say, well, then just repeat the injection every 3 to 4 months, we have seen that there are some drawbacks to that. Repeated cortisone injections over time are actually not healthy for the knee joint, or probably any joint for that matter. Repeated injections actually weaken the cartilage further, which leads to further degeneration of the cartilage. It weakens the bone underneath the cartilage at the joint surface, causing stress fractures, which in and of themselves can cause pain, and they have been shown to increase the risk of infection after surgery if you had a cortisone shot within 3 months leading up to surgery. So, for example, if I gave a patient an injection today and they called in 2 weeks and they said, well, nice try, Dr. Wahl, that shot really didn't help. Why don't we just move forward with replacing my knee? I have to tell them we need to wait 3 months before we can do your surgery, because it takes about 3 months to get that cortisone absorbed out of the knee joint. Otherwise, we risk infection after surgery, which, as I mentioned earlier, is a major problem. So the patient kind of needs to be aware of that in their decision-making process. The gel injections usually require insurance authorization. They are expensive. Sometimes insurance plans will not cover these shots. Sometimes they will demand that we try a cortisone injection first. The difficult thing with the gel injections, and they've been around for decades now, is that the studies kind of show mixed results. Some studies show good benefit and some studies don't, and therefore insurance companies don't feel like there's enough power in the data to support, their widespread use, or at least them covering the cost of the injections. Okay, so we've kind of gone through up to this point, we've gone through all the, I would say, non-surgical or conservative treatment options. Now we're going to start um, running into and going through the surgical options. And I want to introduce this concept of a partial knee replacement. This is not something that I myself do, and I'll kind of explain why here. But just in general, surgeons will sometimes divide the knee up into three compartments. You have an inner knee compartment, what we call the medial compartment, as you see in the slide. There's an outer compartment called the lateral compartment. And then the third compartment is underneath the knee joint, or excuse me, underneath the kneecap. Now, of course, when you open up a knee, when a surgeon opens up the knee, these compartments aren't divided or walled off from each other. It's just an open space. But sometimes you can have a patient who comes in who has arthritis that's mostly confined to just one compartment of the knee, more so than the other two compartments. And therefore, theoretically, they might be a candidate for a partial knee replacement. You're just replacing that one side of the knee, not a complete or a total knee replacement. And I will tell you that this is probably the most controversial issue in orthopedics, and has been for years and continues to be today. And why is that? Well, I'll say that if you go to an orthopedic meeting or convention, you're going to have, kind of half the room divided, where, surgeons on this side of the aisle will give you a very enthusiastic answer as to why they think doing a partial knee replacement is perfectly fair and valid. And then on the other side of the room, you'll have other surgeons who enthusiastically will explain why we shouldn't be doing partial knees. We should just be doing complete knees. And I tend to fall more in the camp of a complete knee replacement. The data is very clear that partial knee replacements do have a higher rate of needing a second surgery. And what is that second surgery? That second surgery is converting them from a partial knee replacement to a complete knee replacement. And the reason why I think in the majority of cases is probably because there was unrecognized or underappreciated arthritis in the other compartments of the knee. And the x-rays may have shown bone-on-bone arthritis on the inside of the knee, and the other side of the knee looked okay. But if you were to go in there and look, we probably see there was some degeneration of the cartilage throughout the knee. So if you just replace one side, the patient will continue to have pain coming from the other compartments of the knee. And that's why, at least in my practice, I very rarely meet a patient who I think is a candidate for a partial knee replacement. So what I do is a complete knee replacement, or we're replacing all three compartments of the knee. And I'll bring up my model here. I hope everybody can see this okay. This is a plastic model of a knee replacement. So you can see up here, this is the femur or the thigh bone, the tibia, there's the shin bone. This is the femoral component. Beneath that is the tibial component, but sandwiched in between here is this kind of plastic, this white plastic insert, and that's what cushions these two metal pieces from each other. Okay, so now we're really going to get into the weeds here and get a little technical. This is kind of shop talk, but this is where our technology is going to come into play. Um, I need to kind of explain this concept of alignment before we talk about ortholine and lantern. So if you drew an imaginary line from the center of the hip down to the center of the ankle, that line should go somewhere through the center of the knee, plus or minus a few degrees. Um, and as I said earlier in the talk, we sometimes see patients who are fairly bow-legged or knock-kneed, and if we did a full length x-ray of their leg, we would see that line that should go through the center of the knee actually doesn't. That line falls outside of the knee somewhere. So our goal in knee replacement surgery is to try to straighten that knee back out into proper alignment, try to get that line, that imaginary line, to go back through the center of the knee joint. And why is that important? Well, because with proper alignment, we see improved recovery times, we see less pain. It reduces the stress on the knee joint and the stress on the implants, in particular, that plastic insert that I showed you. And if it reduces the stress on the implants, then we think and we hope that that's going to lead to longer lifespan of those implants, or what we call survivability. The average knee replacement, should last 20 years, sometimes longer. There's a lot of factors that go into that, and alignment is certainly one of those major factors. But if we can get the knee back to proper alignment, then that should lead to reduced stress on the knee replacement and lead to longer life of the knee replacement. And that's, I think, particularly important now that we're starting, well, not started, we have been doing more and more knee replacement on relatively younger people in their 50s. And if I told them it will last 20 years, well, they come back at 70, they still may have another 15 to 20 years of life left in them. And then now they're older, theoretically less healthy, and now we have to open up their knee again and redo the knee. And the second surgery is never quite as rewarding as the first in terms of patient satisfaction outcomes, and it's a more complicated surgery. So ideally, we'd like to do one surgery that will last the patient their lifetime. And this is where Ortholine and the Lantern technology from Ortholine come into play for me. It helps me get my alignment during surgery. You might call that form, and better form will lead to better function for the patient. Okay, so what is Lantern exactly? Well, it looks like, kind of looks like a cell phone, really. It's about the size of a cell phone. It's a little thicker front to back. It has these sensors inside of it that we call accelerometers and gyroscopes, and all of this is a bit over my pay grade. But I use this device in all of my knees. And Lauren, I don't know if John's listening out there somewhere, but he could probably tell you better than I could. Like I said earlier, I've been in practice for over 14 years. I think I've been using this for over 12 years now, Ortholine. And I think I
With our
was
first generation, our
yeah,
Ortholine Plus unit, all the way to our Lantern unit, which was released in 2021.
yeah, yeah. So, and I think I was the first in Iowa to start using this technology. So I've been using it for a while, and I use it in all of my knee replacements, regardless of how deformed the knee may be. And what it's doing essentially, is it's helping me identify the center of the hip joint and the center of the ankle joint, and then from there I can find the center of the knee joint, and then I can make adjustments um, um, to the knee in terms of how much bone I need to remove when I do a knee replacement and the angle at which I cut the knee too, so that we can once again get that knee back into better alignment. And what I like about Lantern and Ortholine is that it gives me real-time feedback, and the device is right in the surgical field. Okay. Um, I'm staring right at it when I'm doing the procedure. Unlike, let's say, robotic assisted surgery, where I have to look over here at some computer on the other side of the room, and I'm turning my attention away from the knee joint. Furthermore, the computer communicates with the robotic arm, which is attached to the side of the bed, which gets in the way of your surgical assistance. The robot requires that we drill some large pins into the femur and the tibia, and the sensors attached to those pins. Sometimes those pins can cause fracturing of the bone. It adds a lot of time to the case, and robots are, quite frankly, they're expensive, north of $1 million, and that computer needs a software update every year or every other year, and that's another, $250,000 to $500,000. The Lantern is like I said, it's portable. It's the size of a cell phone. And it stays right in the surgical field. I don't have to look away. It doesn't get in the way of my assistance. It's telling me exactly what I want to know, that I would want to know from a robot or computer assisted surgery. It's giving me all the information that I would otherwise get from a robot, without the extra expense and the time and the risk involved with a robot. And I can make adjustments on the fly. Um, and why do we even use technology in the first place? Was there a time when we weren't using technology at all? And the answer is simply, of course, there was a time where we didn't have this technology, and there were ways of trying to identify the center of the hip and the center of the ankle and adjusting your cuts to try to get the knee in better alignment. But often this was a bit of eyeballing it and guesswork. With Ortholine, with Lantern technology, it takes that guesswork out of it. And that's why I enjoy using it. And I've been using it, like I said, for years. And once again, it's the size of a cell phone. And we use it because it gets me to where I want to go. Sometimes we call these navigational aids. Think of it like a GPS. It's getting you where you want to go. For the surgeon, where do we want to go? Well, once again, we want to get that knee in better alignment. So how exactly does it work? Well, in this picture, what you're seeing is the tibia or the shin bone. There is a bracket that attaches to the shin bone. Onto that bracket, we place a sensor, and then we place the Ortholine device. Pardon me. And then I'm basically telling the unit where the inside of the ankle is and the outside of the ankle is, as you can see in the lower part of that picture. And then I'm also telling it the slope of the upper tibia or the upper shin bone, how much does it slope downwards? And then it tells me where I'm going to make the angle of my cut or where I need to make the angle of my cut. And if I want or if I need to, I can adjust that. But like I said, this kind of takes the guesswork out of it for me. I'm not using some rod that I'm dropping down outside the leg and just kind of eyeballing where I think the center of the ankle is. This is telling me precisely where that is. On the femoral side, so that was the tibial side we looked at. On the femoral side, very similar. There's a bracket that attaches to the femur. Once again, the sensor and the lantern device attached to that bracket. And then, so you can see here, here's the bracket that attaches to the femur. And these are small pins. These are not large pins. These are small pins. And then through this maneuver here, I just simply, lift the knee up, down, and then side to side. And that inertia there, that movement there, will tell the unit where the center of the hip is. So once again, I don't have to guess. I don't have to put a rod up the femur or outside the femur and kind of guess where the center is. This will tell me precisely where the center is. And then once again, I can determine how much bone we remove and at what angle we remove the bone. Okay. So this is once again kind of going over the steps of the femur and determining the center of the hip joint. I think the animation showed it best. This is the going back to the tibia, how we do this. This is that bracket that attaches to the tibia. We have a little strap that wraps around the calf. And then once again, the lantern device attaches to the bracket. And then I tell it where the inside and where the outside of the ankle is. And now it knows where the center of the ankle is. And then I can set my block to cut how much bone I want at what angle I want. So like I said, it just, for me, it takes the guesswork out of this. And we can sometimes get pretty impressive corrections. And in fact, I've got a few x-rays here. Yes, that I'd like to share with you. So these are patients of mine. Their names have been blurred out here. These were recent cases within the last month of my surgeries. This is where I wish I had an arrow or a cursor, but I don't. So I'll try to explain this as best I can. The picture on the left-hand side of the screen is an individual that has a pretty typical valgus knee or what we call a knock knee. So the majority of her arthritis was on the outside part of the knee. And you can see there's virtually no space between the thigh bone and the shin bone. They are rubbing directly on each other. And that knee looks like it's angled in. That is a knock knee or valgus knee. She obviously has had her left knee, which on the first picture is actually on the right-hand side of the screen. So imagine if she were standing looking back at you. So her right knee is on the left-hand side of the screen, and her right knee is on the, her left knee is on the right-hand side of the screen, if that makes sense. She's had her right knee replaced elsewhere. That was done years ago. She came and saw me about her left knee. And then if you look at the right-hand picture there, we can see now what her knee looks like after replacement. You can see now she's got a nice straight knee, no longer knock-kneed. And that's the power of Ortholine lantern technology. Is we're taking this knee that was clearly out of alignment. Once again, if you drew an imaginary line, that line would have fallen outside of the center of the knee joint with ortholine. Now we've gotten it back straight, and now that line passes through the center of the knee. She can see it, she can feel it, and she's happy for it. So that case is a pretty typical knock knee or valgus knee. The next picture here is a pretty significant varus knee or bowed knee. Now, once again, I'll kind of start with the preoperative x-rays, which are on the left-hand side of the screen here. This is actually a fairly young patient who is in her early 50s. She is obese, probably heavier than I'd like her to be leading up to surgery. But she clearly has advanced osteoarthritis. My guess is that she probably had a genetic predisposition, and with the added weight, it led to severe osteoarthritis, in particular of the inside of the knee joint, and that's why her knee is bowed. Now, these pictures look a little confusing. And the reason why is that the first picture on the left-hand side of the screen, we tried to get both knees into the same image. We couldn't, and some of that is her size, but some of that is how bowed her knees were. So what you're seeing in the furthest image on the left is her right knee, and we only partially got her left knee in that image. And the x-ray technician actually had to do a dedicated x-ray of her left knee. And obviously both knees bother this individual. I told her, pick one, whichever one you want to do first, whichever one bothers you the most. And she chose the left knee. So you'll see that picture on the right-hand side of the screen. That is her postoperative x-ray. And now we can get actually both knees in the same x-ray because we don't have that significant bowing deformity there. You can see that knee is much straighter. Obviously, she's going to need to have her right knee replaced at some point. She's only 2 weeks out from surgery, so she's in no hurry to get any of this, to get her right knee done. But once again, I brought up these two x-rays to show you kind of the power of Ortholine with the Lantern technology, and how I use it in my practice. All right, and with that, I guess we'll keep the phone lines open for a little while longer and see if there's any questions.
Yes, we do have a couple questions from the chat. Thank you, Dr. Wahl. The first one, going back to kind of the last slide you were talking about the patient who was obese. For the patients on the line who are watching this call and feel like they fall into that category, do you prescribe weight loss medications to your patients, or do you refer them back to their primary care? Is there a minimum weight or BMI that you're looking for these patients who do think they could be a candidate for a knee replacement, but they're worried about their weight?
Yeah. Yeah. So the first question, I myself do not prescribe any weight loss medication. I do often refer them back to their primary, and sometimes the primary care provider isn't, completely comfortable managing that either. And I think, sometimes the best results usually are achieved with a team approach. So we usually do need to, have them see a dietitian, a weight loss specialist, refer to a weight loss center. The second question, do I have, I guess, a cutoff when I would operate and when I wouldn't on an obese patient? I would tell you historically, we've kind of made a big deal of something called BMI or body mass index. And it's a number that we derive from a formula that takes into account your height and your weight. Different surgeons have different cutoffs. Um, I would say in general, my cutoff is 45, which I think is generous. Um, Most surgeons, 40 is their cutoff. Uh, I think though more recently we're maybe realizing that um, we can't just solely rely on the BMI. We have to look at the patient's, entire health. Maybe they have a BMI of 40, but their diabetes is, out of control. Or maybe they have a BMI of 45, they're right at the cutoff for me, but they have a pretty skinny knee. To me, that's an easy surgery. But if they have a BMI of 40 and they have a lot of adipose tissue around the knee, we found that a lot of adipose tissue is really what causes a lot of wound healing complications and increases the risk of infection. So we can't just exclusively include or exclude patients based on BMI alone. We need to kind of look at the whole picture. We also need to look at like I said, the adipose tissue, the fatty tissue that surrounds the joint. And that's true whether it's a knee replacement or a hip replacement.
Great, thank you for providing some details there. If you want to advance to the next slide, I know we're just at time here. So for those of you on the line, a few different ways to contact Dr. Wahl's office. You can schedule an appointment by calling the number, clicking the link in the chat, or you can also scan the QR code. I did want to end with one last question, though, in the chat, just talking about recovery time. If you could just spend a minute or so about the recovery time for the total knee. How long is it? What's typical length for the hospital stay? And then when can the patient expect to get back to their daily activities, such as walking or cycling? If you could talk a little bit about that recovery time for your patients.
Sure, sure, and of course um, that answer will kind of vary dependent on the patient, but just talking in general, I would say the surgery takes about 2 hours. Um, I do keep my patients one night in the hospital. It's still considered an outpatient procedure because usually they go home the next morning. Um, The first 6 weeks are, I think, the hardest. That's when the knee is the most swollen, the most stiff, the most sore, and then you're coming to physical therapy 2 or 3 times a week, and the therapists are trying to get you to move your knee, and that just kind of further aggravates things. But you'll notice kind of weekly improvement, even beginning from week 0 to week 1. You'll notice weekly improvement for up to a year. Now, the biggest gains, I think, are those first 12 weeks or 3 months. So, I tell every patient, usually by 12 weeks, you're finally feeling some satisfaction from this new knee. You're thankful that you had it done. Sometimes the first few weeks, there's a sense of why did I do this? But um, everybody gets better eventually. They kind of go about it at their own pace. Return to work or activity, I guess it would depend on the activity. If they have a desk job, they might be able to get back to work within 6 to 8 weeks. If they have a more physically demanding job where they're on their feet a lot, I might tell them it might be 8 to 12 weeks before you feel comfortable. Riding a bike, I think that's kind of a matter of how well the knee can bend, not only to kind of get your leg over the seat, but also cycle. And I would say at least give it 3 to 4 weeks, but after that it would be kind of to your tolerance.
Great. Well, thank you. That answered our last question here in the chat. Again, I want to thank everyone for joining and participating. The link to the website is in the chat. You can learn a little bit more about Guthrie County Hospital there in Dr. Wahl's practice. You can see the phone number to contact, or you can scan the QR code. So again, thank you everyone for attending. We hope you found this informational webinar helpful, and hopefully it can help you in making your future healthcare decisions. So thank you for attending, and a special thanks goes out to Dr. Wahl. Thank you for being here with us tonight and presenting all your knowledge and sharing a little bit more about your practice.
Yeah. Thank you. Thank you.
Thank you, everyone. Have a great night.
Okay, we're good, Lauren?